This case illustrates the use of the orbitozygomatic craniotomy for resection of a pontomesencephalic cavernous malformation. This 21-year-old male presented with subtle left-hand motor discoordination. 6 months prior to presentation, he experienced an episode of sudden onset headaches, diplopia, and left-sided hemiparesis that led to the identification of this large pontomesencephalic cavernous malformation. The CT scan demonstrates the hematoma of various ages associated with this lesion, while the magnetic resonance images demonstrate the classic appearance of the cavernous malformation located eccentric to the right side in the pontomesencephalon. This anatomical dissection demonstrates the pertinent anatomy for removal of the lesion from this location. 2 ventral safe entry zones have been described for gaining access to the midbrain. These include the perioculomotor safe entry zone, located lateral to the third nerve between the PCA and the SCA, and the intrapeduncular fossa safe entry zone, located in between the perforators arising from the top of the basilar artery. This lesion was approached using a perioculomotor safe entry zone. This anatomical dissection demonstrates the location of the motor fibers traveling in the medial 3/5 of the cerebral peduncle. These are highlighted by the orange outline. Given the location of the motor fibers, it is possible to enter the midbrain, medial to these motor fibers and lateral to the third nerve between the PCA and SCA to gain access to lesions in this location. This is nicely illustrated using this fiber tract dissection specimen. Using an orbitozygomatic craniotomy, the sylvian fissure is widely split to arrive at the basal cisterns. Opening of the cisterns over the carotid artery allows for release of cerebrospinal fluid. The key to performing this operation is for the surgeon to develop a working trajectory lateral to the third nerve. When doing so, arachnoid bands tethering the third nerve to the tentorium and the temporal lobe are cut sharply, allowing the third nerve to be medially displaced. This maneuver allows the surgeon to arrive at the brainstem lateral to the third nerve at a point that is safe to enter midbrain for removal of this cavernous malformation. The neuronavigation is used to choose an optimal point of entry. The point of entry should be the point that minimizes transgression of the brainstem. In this case, it so happens that the optimal point of entry is at the perioculomotor safe entry zone. A small opening is placed into the brainstem, releasing the cystic component of the cavernous malformation. The small opening is expanded using a spreading technique, and the spreading technique should generate an opening large enough for the small suction and the bipolars to be placed into the cavity. Next, the cavernous malformation is identified and gently dissected using a combination of blunt and sharp dissection to remove the lesion. The suction provides hemostasis as well as serves as a dissector, allowing for dynamic retraction and mobilization of the lesion from the cavity. After the lesion is removed in a piecemeal fashion, the cavity is inspected for small residuals. Hemostasis is obtained. And care is taken to preserve the developmental venous anomaly associated with the lesion at the depth of the resection cavity. The lesion is removed completely. Postoperative magnetic resonance imaging demonstrates complete removal of the lesion. The patient experienced no change in neurological exam postoperatively.